Good morning, everyone. A warm welcome to all of you to today's webinar organized by the Society for Health Research and Innovation Academy. We truly appreciate your presence and commitment to continuing professional development. Before we begin, let me share a few important points regarding the webinar proceedings. The link to join the webinar will be available until 9:50 a.m. and access to the session will close promptly at 9:50 a.m. Late attendees will not be admitted beyond this time. By participating in this program, you can earn 1.5 CPD points. Participants must remain until the end of the session to receive your CPD certificate because the Shri webinar series strictly adheres to NCPD guidelines. I hope you will keep your microphones and videos turned off throughout the session to ensure a smooth webinar experience to everyone. You can ask questions via the chat options at any time, and your queries will be addressed at the end of the session. If you have a very specific questions to clarify, which you think you cannot ask here, you can email us on office313@gmail.com, the address shown in the screen now. After the webinar concludes, stay another few minutes and ensure you fill out the Google form provided in the chat box with post-assessment questions to receive your CPD certificate through email. This form must be submitted before 11 a.m. today. Please recheck your email address before submitting the feedback form at the end of the lecture, as many doctors miss their certificates due to providing incorrect email addresses. Kindly submit the form correctly at the end of the webinar by 11 a.m. today. And please note that you will not be eligible to have the CPD certificate unless you follow the guidelines and answer the post-assessment question. Moving on to the topic, ENT in general practice. I believe this is a highly relevant and important topic in our day-to-day medical practices. So we have a well-versed resource person today with us, Dr. Sanjeevani Rupasinghe, consultant otorhinolaryngologist working in Sri Javadhanapura General Hospital. And over to you, Dr. Sanjeevani, Madam, to continue with the informative session on ENT in general practice.
Good morning, everyone. So the today topic, common ENT problems in general practice. I hope at the end of this session, you will be benefited from this. Today, I am planning to introduce you to common ENT problems that you encounter in general practice with a special emphasis on vertigo and hearing impairment. This being a very vast topic, I might not be able to produce each and every problem today, but I hope the common issues that you encounter will be covered in this session. So we'll start with the ear issues that you can encounter. So I hope you all are familiar with this common picture where the ear structures are shown, starting from outside the pinna, the external ear canal, eardrum, the middle ear structures, including the three ossicles, and the most important structure in the middle ear, the eustachian tube connecting the middle ear to the nasopharynx, and then the inner ear structures, the cochlea, semicircular canals, and the nerve delivering all the signals up to the brain. So here, the common issues that you encounter is earache, ear discharge, ear swelling, hearing impairment, balance, and vertigo. When you encounter a patient with earache, this could be due to two reasons. One is an otological condition where the issue is relevant to the ear structures, or secondly, it could be a non-otological cause referred pain from the surrounding structures. So if you cannot find anything relevant in the ear, external canal, or the eardrum and the middle ear, by examining the patient, you have to look for the surrounding structures to find a referred pain causing all these problems. The referred pain commonly occurs from the temporomandibular joint, which is a which is very closely related to the ear. So if you can keep your index and the middle finger just anterior to the tragus here, ask the patient to open and close the mouth like that. So the dysfunction of the temporomandibular joint will cause pain in the temporomandibular joint. And the other important thing is the oropharynx. Uh, the tonsil and the surrounding structures can give rise to a referred pain in the ear. So you have to open the mouth and look for the inside uh, to see whether there is anything in the oropharynx causing this ear issue. Make sure you examine both the temporomandibular joint and the oropharynx. If you cannot find anything specific in the external ear canal, ear pinna, and the eardrum. This is a picture of a perichondritis. We are going from out to inside. You see all the signs of inflammation is there. The pinna is swollen, red, and warmth is there. Usually it is due to an infection with the pseudomonas, and you usually need systemic antibiotics. Oral antibiotics might not help in severe cases, but in a milder form, you can give oral antibiotics and see the progression. The important thing is this infection can lead to a compromised blood supply to the inner cartilage. Uh, if you do not treat this on time, the inner cartilage is going to necrose, avascular necrosis, and the patient might end up with a cauliflower ear. The ear, the pinna, the structure can get disturbed. And this is another common condition that you encounter and misdiagnosed. You get a swelling, localized swelling in the pinna. It is not hard, not firm, usually cystic because it's a fluid-filled cavity. If you do a needle aspiration, you might see some straw color blood stain fluid coming out of it. This is not an infection. It's a perichondrial cyst which usually occurs with trivial trauma to the pinna. This fluid accumulates between the perichondrium and the cartilage. It lifts up the perichondrium from the cartilage, and the perichondrium gets its all nourishment, oxygen, blood, everything through the lining perichondrium. So the cyst has lifted up the perichondrium. So again, a similar scenario like the previous one. The cartilage doesn't get blood supply, avascular necrosis if you don't treat this on time. You might see a little bit of redness over the skin there, uh, mimicking a infection, tending to give antibiotics to this condition, but antibiotics not going to help, aspiration not going to help. You have to do a surgical procedure, make an incision there and drain all the fluid and put sutures so that it won't accumulate again. It's like a balloon. Even after aspiration, it is going to fill up again. So perichondrial cyst, you have to keep in mind. Both conditions, if you don't treat on time, you can end up in a cauliflower like this. The next, you can get the sinuses like this. You can see only the sinus opening outside, anterior to the pinna, preauricular, or usually missed the auricular sinuses. Auricular sinuses are located on the pinna, not anterior on. So if you see a uninfected, non-infected preauricular or auricular sinus, it is better to get it out before waiting to be infected. Once it is infected, usually antibiotics and abscess drainage should be done. Uh, and once the infection is settled, the sinus needs to be removed surgically, otherwise, to keep on infecting, keep on producing abscesses, keep on causing problems. Sometimes this preauricular or the auricular sinuses, the end is at the back of the pinna. So you get a abscess at, sorry, post-auricular area, you get an abscess. Please look for a sinus anteriorly, because even though the opening is anterior, it can go at right at the back, causing the infection at the post-auricular area. So post-auricular abscesses, post-auricular infections, look for a sinus anteriorly. And the common other issue, earwax. So what would you do with earwax? Is it harmful? Everybody asks us whether we need to remove earwax. Actually, earwax is helpful. We all produce earwax, and it automatically comes out because there is this epithelial migration process starting from the eardrum. Outer squamous epithelium, starting from the eardrum, there is a place called ammu where the handle of the malleus is attached to the eardrum. From there onwards, the epithelium is migrated outwards, taking everything inside. So whatever the produced wax, debris, everything is taken out by the those mechanisms. So ear is a self-cleansing organ. You don't have to remove earwax. But in 10% of the population, this normal epithelial migration process is not optimal. So those 10% of the population tend to accumulate earwax. Uh, so in that case, the earwax is impacted, causing pain, inflammation in the outer ear canal. Then only you have to remove earwax. Uh, a salient feature is the tragal tenderness. Anything causing outer ear canal inflammation, edema, infection, anything in the outer ear canal, you press on the tragus and that causes pain. Without tragal pain, it's unlikely that there is a significant inflammation in the outer ear canal. So how do you remove earwax? Uh, the best way of removing earwax is under direct vision with a headlight or anything. Directly you scoop it out, or with a wax hook you take it out. The other method is to use water, ear syringing. But if you are not competent, or if you don't know the proper technique, ear syringing can cause harm than good. We have come across patients with eardrum perforations, and then hearing impairment following ear syringing, because now you cannot see the underlying tissues or the state of the eardrum with wax overlying the uh, eardrum. So the patient might have a eardrum perforation which has not been diagnosed previously. So if you put water, this water jet can damage the middle ear structure, especially the round window membrane, causing permanent hearing impairment. So other thing is, if you put some wax solvents, uh, like sodium bicarbonate drops or olive oil ear drops, to soften this wax out, it might come out automatically, and it is easy for you to remove this wax. Even gentle syringing might bring out the soft wax rather than the hard wax. So you don't have to exert pressure or a hard syringing to remove soft wax. So what I would advise is, if you see impacted or the ear canal is full of wax, use wax solvents for minimum 5 days, and then if you don't have any instruments or anything to remove, just gentle syringing would do the rest. Um the other thing is otitis externa. As I've told you, external ear canal is more prone to get infections because of the anatomy. It's a tortuous structure, and because of the skin lining, there's sweating, and moisture can lead to infections, bacterial, fungal, and also skin diseases like eczema and psoriasis can cause ear canal inflammation and infection. If you get a patient with repeated episodes of bilateral otitis externa, it's refractory to medication. It's bilateral. It's not only one side coming on and on off again. Look for a skin condition like eczema or psoriasis. We get bilateral ear otitis externa with eczema in the outer ear canal. So, as I've told you, the trigger tenderness is the salient feature, and you will get discharge and swelling and oral antibiotics. And about this earwig, when you have a inflamed or edematous, swollen ear canal, your drops might not go in. The oral antibiotics and local drops, antibiotic drops might not go in. So you can use a small wig, a pahantire small wig made of out of cotton or bandage, about 2 inches, tiny wig impregnated with whatever antibiotic uh, cream, local application. You just put it in the external ear canal. Don't push it hard. You don't need a big one. Minimum 2 inches, maximum 2 inches, impregnated with antibiotic cream. Just put it at the meatus, and you put the drops or the local antibiotics, anti-inflammatory, on top of that wig. So that will have a local action, reduce the inflammation, pain, swelling, everything, and you will be able to see the inside properly after about a day or two. Otitis externa, you can give oral antibiotics combined with antibiotic ear drops. And if the condition is severe, you can even try a small uh, ear wig. These are few photographs of the common infections that you encounter in the external ear canal. Uh, a simple light might not visualize these things because the infection might be at the end of the ear canal. So this is white patches are candida, a fungus, and this is again a common thing, aspergillus. You see the black uh, hyphae. This is typical of aspergillus fungal infection. So, what would you do with these fungal infections? Uh, Important thing is you advise the patient not to let water in any ear condition, ear infection, outer ear canal. You don't let water in the ears. Water, the moisture itself can aggravate the infection. So how do you do that? You can either have a earplug or a cotton ball impregnated with Vaseline, acts as a uh, 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 block. So you can block the ear canal with cotton ball with a Vaseline or a earplug to not to let water in. And the fungal debris, if possible, needs to be removed. And usually, uh, this settles with antifungal uh, drops. Uh, but it has to be continued for more than a week. It's not like a bacterial infection. The response is um, uh, obtained with prolonged use of uh, antibiotic uh, antifungal drops. Uh, the other thing is uh, impacted wax causing wax keratosis. This is a very painful condition. You might not be able to do anything in the outpatient clinic. Usually, because of the pain and the swelling, we need anesthesia to clean out the external ear canal. You see a lot of debris, keratin debris, impacted, causing local inflammation and edema of the canal. So if you see a patient with severe earache, with uh, severe edema of the canal, with a history of wax impaction, consider this condition called keratosis obturans or wax keratosis, which needs proper cleaning under anesthesia. And then a few words about foreign bodies in the ear. You can encounter anything, starting from beads, pebbles, anything in the ear. So how are you going to remove this? The foreign bodies which doesn't absorb water, uh, you can try a gentle syringing to remove the foreign body out. But the pebbles, weeds, and all, with the water pressure, it can go and impact and damage the uh, tympanic membrane. So, this also, and if possible, better to remove everything under direct vision. Other thing is insects. Another common issue. You can get cockroaches like small insects or ticks. Tick again is undiagnosed for about a day or two. Once the inflammation and the swelling starts, it gives an immense pain in the external ear canal. Uh, uh, that again you have to remove, but if the tick is on the tympanic membrane very close to the annulus, might not be able to do it in the outpatient clinic. In that case, might need anesthesia. And if you see any damage to the canal, again you can use a small wick, as I've told you, about 2 inches, impregnated with antibiotic ointment for about 2-3 days in the ear canal, and put the drops on top of that, so it will deliver the drugs effectively inside, rather than just putting the drops onto the closed or the edematous ear canal. Uh, Going further inside, uh, the middle ear conditions, acute otitis media. Usually after a respiratory tract infection, 95% of it is viral. The salient feature is that the children, they wake up in the middle of the night claiming earache. So they are down with flu, respiratory tract infection, good night sleep. They wake up the next day, early morning with earache. So if you see a red, bulging, angry looking, inflamed tympanic membrane, the issue is in the middle ear. So antibiotic ear drops is not going to help unless the tympanic membrane is inflamed and meningitic, because it's not going to go inside. If you have fever, you can give antibiotics, but keep it in mind that this is 95% of the time the common cold is viral. Most importantly, uh, you need to give nasal drops or nasal sprays, because I told you the one of the important structures in the middle ear is the eustachian tube connecting the middle ear to the nasopharynx. So this eustachian tube needs to open up and the pressure needs to be balanced out, so that the pain is relieved. Otherwise, the because of the pressure in the middle ear, continuous pain. However much you put antibiotic ear drops, the pain is not going to stop. So if you do not release the pressure inside with nasal sprays and antihistamines, this fluid is going to leak out through the eardrum to the external ear canal, relieving the pressure. So this is not a eardrum perforation, but micro perforations, just leaking the middle ear fluids into the ear canal. In that case also, you can give antibiotic ear drops, because now there are microperforations in the eardrum, so that your local application, the drops, is going to go in. Importantly, analgesics and ear drops if the eardrum is inflamed, and most importantly, nasal sprays and the nasal drops. If you ask me what is the best, is it the nasal spray or the nasal drop? I would say I prefer nasal spray, because compared to the nasal drop, the spray has less amount of medication, but because it's a spray, it is going to get deep inside. You just squirt it up, it's going to reach the nasopharynx, where the eustachian tube opens up. But if you don't put the nasal spray correctly, it's not going to go in. So even if you get more concentrated medication in the ear drop, nasal drop, the delivery is bit complicated in the drop rather than the spray. So I personally prefer to put nasal sprays, but it's again two schools of thoughts. People use ear drops, nasal drops, and the sprays both. And this is again a picture showing the cartwheel appearance. You get all dilated blood vessels. The issue is in the middle ear. This is another common condition causing ear fullness and earache, glue ear, fluid levels in the middle ear. This is again not an infection. People tend to give antibiotics, but again, any middle ear condition, ear drops is limited help, but ear nasal sprays, antihistamines is going to help. Uh, if you get fluid or glue in the middle ear, it is not going to resolve within a day or two. It's a very gluey, thick material, sometimes takes about a month. So you have to educate your patients that it will take some time to resolve. Again, a classical picture showing trapped air bubbles inside. So the problem is in the middle ear. Middle ear issues, consider giving nasal sprays, nasal drops, because the eustachian tube has to open up and ventilate the middle ear. If you don't treat these middle ear conditions on time, this glue or the effusion, the middle ear glue will retract the eardrum. It will retract the eardrum, and the retracted eardrum is going to paste it onto the inner wall of the middle ear. So you get the eardrum retraction and the prominent ossicles, causing hearing impairment, because this ossicular chain is not moving as usual. Because of this retraction, it's being held up and pasted onto the inside wall of the middle ear. So that is why we emphasize that this glue ear, any fluid in the middle ear, needs to be treated timely. And mastoiditis is another condition that you can get pain and swelling of the outer ear. The mastoid is at the back of the pinna, postoral area. So the pinna is pushed forwards and you get a swelling and a red inflamed features of acute inflammation. The common mistake that we do is we press on the tragus. We press on the tragus to elicit pain in the mastoiditis. But uh, we press on the mastoid tip. Sorry, the mastoid tip is very hard, and it's not going to cause any pressure in the mastoid. The least resistant area is right up here, the least resistant area, and the swelling again is there. So if you press there and if you see a swelling up there, is likely mastoiditis. But don't press on the mastoid tip. It's not going to do any not going to elicit any clinical signs like pain and tenderness, because it's a very hard structure, the mastoid tip. It's not going to collapse. Mastoiditis again treated with antibiotics, systemic preferably. Again, nasal sprays, because the it's going to drain through the middle ear, through the eustachian tube into the nasopharynx, unless you have a eardrum perforation, which brings the infective material or the discharge out. Then the eardrum perforation. Eardrum perforation also can be of two types. A chronic eardrum perforation due to recurrent infections, where you have a clear margin, a fibrosed clear margin, indicates that this had been there for some time. And other type is a traumatic perforation, where you have a ragged edge, usually following trauma with a ragged edge and a blood clot uh, around. So traumatic perforations are managed differently, and the chronic perforations in ear infections managed differently. So what would you do in a traumatic eardrum perforation? Most of us prescribe ear drops, antibiotic ear drops, which we do not recommend in a traumatic perforation, because traumatic perforation is going to heal on its own. The epithelium is going to form, and it's going to close the gap. The blood clot is beneficial, because it acts as a scaffolding, and the epithelialization is enhanced by this blood clot. So don't try to remove the blood clot. Don't prescribe any antibiotic ear drops, but keep the ear dry. Don't let anything inside the ear, no water, no ear drops, but oral antibiotics, um, nasal sprays to keep the middle ear ventilated and to release the pressure there. And you just allow the traumatic perforation heal on its own. Usually, it takes about a month, 4 weeks. You reassess the perforation. 90% of the time, traumatic perforations without eardrops heals on its own. But large perforations, like causing uh, the whole pars uh, flaccida or the pars tensa perforations, uh, takes more than a month to heal. Sometimes it might not heal even after 3 months. Then you have to consider doing a meringoplasty, closing up the gap. Otherwise, the middle ear is prone to get infections. In the chronic eardrum perforations with infections, uh, we commonly call CSOM, chronic suppurative otitis media. You get a eardrum perforation with a fibrous margin, clear margin. This is not going to heal on its own, and can cause repeated ear infections. In that case, we need to surgically repair the eardrum. This is again a few pictures of chronic perforations or in chronic infections. The other important thing is this cholesteatoma, which is another condition, can give rise to recurrent or repeated ear infections, ear discharge. This is keratin debris. Cholesteatoma is not a tumor per se, but it acts as a tumor, destroying the surrounding structures, causing local pressure. It usually occurs in the attic area, the eardrum, the upper part, the attic. It's the least resistant part. So the attic area, the cholesteatoma accumulates, and it goes in rather than coming out. This can destroy the ossicular chain inside, causing hearing impairment, recurrent infections. So, if you get a patient with recurrent repeated ear infections, ear discharge, don't keep on treating for the simple infections, but look for a cholesteatoma. Uh, you have to see the attic area of the eardrum, and this is a typical picture of cholesteatoma. So if you suspect a cholesteatoma, refer the patient to a specialized center where you need a mastoid exploration, clearance, repair of the perforations. Recurrent, repeated ear infections without any response to local treatment, refer to a specialized center. And few words about vertigo, because vertigo can be of due to many reasons, and ear uh, has got conditions which are treatable. It's an illusion of movement. Either the patient has to rotate or the surrounding has to rotate. It could be a subjective or an objective vertigo. Uh, when you have conditions in the inner ear, you get vertigo. So it is a very complex slide where you have how the balance is maintained. Only you have to remember 70% of the balance is maintained by the vision, 15% of by the inner ear, and the rest 15% by the neurology. So, what are the common causes of vertigo in ENT practice? ENT origin. We call it a peripheral origin vertigo because the issue is in the outer ear. Common one is BPPV, then you get the Meniere's, then labyrinthitis, vestibular neuronitis, and many other less common causes. The problem is in the semicircular canals, three sets of semicircular canals attached to 90 degrees of each senses the rotation of the ear. BPPV is due to otoconia. It's a classical history you get. Uh, if a patient comes and tells you that they have vertigo, make sure you ask direct questions to see whether this is a ear related one or a central or neurological cause. BPPV is due to otoconia, usually in the utricle and the saccule. For some reason, they dislodge into the semicircular canals, and with each and every head position, they rotate inside the endolymphatic compartment of the semicircular canal. So the history is vertigo with head movements. Doesn't last for a long couple of minutes or seconds. If you keep the head still, it settles down. It settles down, and the vertigo is disappeared. Each and every time you move your head, vertigo, classical vertigo, lasting for a few minutes, settles down. What would you do if you suspect a BPPV? In severe cases, you can give vestibular sedatives like beta histidines and cinericines, but in vertigo, we don't recommend giving stemetil for a long periods. Let's say about 5 days or a week or two, but nothing more than that, the stemetil, but you can give beta histidines and cinericine. PPPV is not going to settle down only with oral medication, but you have to confirm it by doing a Dixol pipe test to see whether this is in the posterior canal or the anterior canal or the lateral canal, and accordingly you can do repositioning maneuvers. You can relocate the otoconia by doing Epley maneuver and so on. But if you are not familiar with these maneuvers, if you are not familiar with these relocation procedures, what I would advise is not to do, not to try, because you can dislodge these otoconia into a different side rather than to the utricle and the saccule, their original position. So posterior canal otoconia you can dislodge into another anterior or the lateral canal. So it is. It has to be done in a proper systematic way. Then the vestibular neuronitis and the labyrinthitis is more or less the features are common. Only difference is labyrinthitis you get hearing impairment, vestibular neuronitis you don't get hearing impairment. Both conditions usually after a viral infection, inflammation of the vestibule and the nerve, you get severe vertigo lasting for hours and days with nausea, vomiting. Vestibular neuronitis, no hearing impairment. Labyrinthitis, there is hearing impairment. So don't label patients as having labyrinthitis if you don't have hearing impairment in those patients. So the treatment is anti-inflammatory for both conditions, which will enhance the recovery. If you don't do anything, it will take some time, maybe a week or two. They keep on having vertigo, nausea, vomiting until this inflammation is settled. But you can enhance the recovery by giving anti-inflammatory. Corticosteroids are indicated in this case, antivirals, and other thing is early mobilization and vestibular rehabilitation therapy, because the balance, the other inputs to the brain and the vestibule needs to be strengthened. Vestibular ocular reflexes, vestibular spinal reflexes, early rehabilitation and vestibular rehabilitation, early mobilization can strengthen these other reflexes and maintain balance. So vestibular neuronitis, labyrinthitis, long hour, long days, vertigo with nausea, vomiting, with corticosteroids are indicated. Meniere's disease again is, I call it a pressure build-up in the inner ear. You get a classical history in classical Meniere's where you, as the fluid build up, you get a fullness, then the inner membrane stretch out, so you get a tinnitus, and then at the peak you get vertigo and hearing impairment. So fullness, tinnitus, deafness, vertigo. Fullness, tinnitus, deafness, vertigo. That is the classical scenario in Meniere's. So if you don't get fullness, tinnitus, deafness, vertigo, specifically ask direct questions and see whether this is classical Meniere's or not. Fullness, tinnitus, deafness, vertigo. So if you suspect Meniere's, what would you do? We need to reduce the accumulation of this endolymphatic endolymph, because this is due to the pressure buildup in the endolymphatic compartment. This endolymph is a continuous circulation, continuously produced and continuously reabsorbed. We assume that there is, if there is a overproduction or decreased reabsorption, normal production, decreased reabsorption, something to do with the endolymphatic circulation. So diuretics like HCT will going to reduce the production. Vasodilators like beta histidine is going to increase the reabsorption so that the endolymphatic pressure is kept at a constant. And intractable vertigo with Meniere's, intratympanic injections also considered, but it's not the first line. First line is diuretic and vasodilators to keep the endolymphatic pressure at a constant. So lifestyle adaptations, general measures, stress reduction, low salt diet also can be of help, but mainly diuretics and vasodilators. So Meniere's fullness, tinnitus, deafness, vertigo, it's Meniere's. So those are the four common conditions that you can encounter in related to ear vertigo, BPPV, Meniere's, vestibular neuronitis, and labyrinthitis. And and the other important topic is the deafness, hearing impairment. You can get uh, a conductive type of deafness or a sensorineural type of deafness. Conductive type, outer ear, eardrum, middle ear, the sound wave is not conducted through properly. Sensorineural, sense organ is the cochlea, neural is the nerve. Sensorineural, two conditions in one name. So damage to the inner ear and the nerve pathway called sensorineural. Conduction deafness, again, impacted wax, otitis media, adhesive otitis media, traumatic perforations, and otosclerosis, where the uh, uh, ossicles are bound together, and conditions like glomus, where you have a middle ear condition, can cause conductive deafness. Sensorineural, again, presbyacousis is age-related. With age, we all grow old, and the system grows old, and the nerves don't function well. In presbyacousis, you get a high-frequency sensorineural loss. Meniere's disease, you get a hearing loss, noise-induced hearing loss. Again, ototoxic drugs, labyrinthitis, those are the common causes. Otoscopy might not reveal anything in sensorineural hearing loss, but a conductive hearing loss, you can get outer ear obstruction, wax, eardrum perforations, and all. Free field voice assessment is essentially done in a clinic environment where you don't have a tuning fork test to confirm the degree of hearing impairment. It's easy to do. You at 1 feet and 2 feet, you test for conversation and whispered voice and see whether the patient hears it. Uh, Tuning fork test, you can do with Weber's and Rene's test again to confirm the type, the conductive or the sensorineural hearing loss. And to confirm that, we normally do a pure tone audiogram and an impedance audiometry, tympanogram. This is a normal audiogram of the right ear marked in red color. Usually this air conduction, bone conduction should be above 20 decibels. This is essentially normal because it's well above 20 decibels, both air conduction and bone conduction. This is a normal audiogram. This is a conductive here. You get a air-bone conduction gap above 20 decibels. If you bridge this gap, it's going to be normal. So this is a pure conductive deafness. This you can see both lines are going below 20. These low frequencies and the high frequencies. High frequencies are more affected than the low frequencies. So it's a sloping high frequency sensorineural type hearing loss. This is a typical of presbyacousis where you get in old age. This is a mixed type of hearing loss. You have a conductive and a sensorineural. Tympanogram type A is AD, AP, BC, where you assess the middle ear. Like in glue ear, otitis media with effusions, and acute otitis media, you get a disturbed tympanograms. So, in hearing impairment, what would be the treatment? For you to treat the hearing impairment, you have to identify the cause. whether it's a outer ear, middle ear, or a inner ear cause, depending on the um, cause you treat. Uh, this I need to emphasize to you all: sudden sensory neural hearing loss, because this is uh, one considered as an emergency, ENT emergency, mismanaged, because we are really not aware of this condition. Uh, Patients usually comes and tells you that the hearing was okay and it went off suddenly. The all of a sudden they wake up the next day morning, the hearing is gone. They give a preceding history of a viral infection also. Then we mistakenly think that this is because of the viral or the glue or phlegm in the middle ear, but it's not. This is a ENT emergency. If you don't treat it within the first 24 to 48 hours, the patient ends up with a dead ear. So the treatment is steroids. How do you identify the sudden sensory neural hearing loss? It's mainly with the history, sudden loss of hearing, and you can confirm it by a Weber's and a Rinne's test. If it is a conductive type hearing loss, as you expect a glue or anything, the Weber's is going to lateralize to that side, negative. But in this case, Weber's is going to lateralize to the other side because there is a sensorineural hearing loss on the affected side. So, if the patient complains of a sudden hearing loss, and you see Weber's test going to the opposite direction, please suspect a sudden sensorineural hearing loss, which is a ENT emergency. Treat within the first 24 to 48 hours. Don't think that this is due to phlegm. Steroids are the mainstay of treatment, and in most of the cases, we give intratympanic steroids, intratympanic injections, because high dose steroids is having a lot of other unwanted side effects. So, intratympanic steroids are the mainstay of treatment. Refer to a specialized center. And few quick words about nasal conditions. You get nasal foreign bodies. And this is a picture that I want to show you. See the two bulgings inside the nose. If you just lift the columella up here, flash your torch, you see two bulges either side. The patient comes with nasal obstruction. And you lift up the columella and see two bulgings on either side of the nose. You think that this is a polyp, which is not. These are two hypertrophied inferior turbinates causing nasal block. Don't mistakenly diagnose this as a nasal polyp. This is not a nasal polyp. This is a hypertrophied inferior turbinate. And see, this is a deviated nasal septum causing closing of one nostril. The nasal septum, the midline nasal septum, it's red. You think that is inflamed, infected, polyp, anything. But this is inferior turbinate hypertrophy, and this is a deviated nasal septum causing nasal obstruction. So if your patient comes with a nasal obstruction, just lift up the columella and see whether there is a significant nasal deviation, septal deviation, or a hypertrophied inferior turbinates causing all these things. This is a picture. See, the one side is hypertrophied, other side is normal, and there is fluid and material in this maxillary sinus. We don't normally do X-rays to diagnose acute sinusitis. Normally, X-rays are not recommended to diagnose acute sinusitis. It's a clinical diagnosis. You can elicit sinus tenderness, frontal sinus tenderness here at the medial edge here. That is the least resistant part. You press on there, sinus tenderness. And the maxillary sinus tenderness here, the least resistant part here. Don't tap on the supraclocrius, infraorbital. Don't tap on those areas. It will definitely give you pain and it will mislead you having sinusitis. This is a complication, preceptal cellulitis, periorbital cellulitis, complication of sinusitis, uh, where you need antibiotics, systemic preferably. So if you get nasal obstruction suspected of sinusitis, again, nasal sprays, antihistamines, antibiotics going to help. Uh, Sorry. See the difference of the turbinate and the polyp. Polyp is a translucent uh, uh, thing, and the turbinate is vascular and it's macroscopically seen more harder than the polyp. Sometimes you can have polyps protruding through the nostril as well. So if you see polyps, you can first try medical polypectomy. Medical polypectomy is that you give nasal sprays, antihistamines, macrolides like clarithromycin, and oral steroids. That is medical polypectomy. Nasal sprays, antihistamines, macrolides, and steroids, oral steroids. This is going to shrink the polyps and ease off the airway, and it's not going to cure you from the polyps, but it can recur. So if your medical polypectomy fails, only you go for a surgical polypectomy where you remove the polyps and clear the nasal passage and the sinuses. Quick word about the larynx and the uh, foreign bodies in the larynx. So foreign bodies can be of any type, coins, nails, anything, pebbles, beads, anything. So, if the patient comes to you with a history of foreign body ingestion, one salient question can differentiate the foreign body. Most importantly, you have to say whether the foreign body is in the trachea or in the esophagus. So, what is the question that you first ask? Uh, just ask the patient or the if it is a child with the parents whether the ingestion while ingestion whether the patient had coughing. Coughing is that the foreign body has stimulated the vocal cords and it has gone into the trachea, or it is stimulating the larynx. If the patient says, no, we didn't have any coughing, no coughing, so very unlikely that it's in the trachea. And the other thing is, if the patient is stable with the foreign body, don't try to make it unstable in your clinic setting. Refer the patient to a specialized center because you tend to do a lot of other maneuvers like Heimlich maneuver. You tend to put the finger in and try to remove the foreign body. But I normally don't try to do anything with a stable foreign body because you trying to do any maneuvers or any procedures, you tend to destabilize the foreign body. The stable foreign body is going to destabilize and cause problems. We have seen patients just by trying to remove it, the stable foreign body goes and sits on the larynx. That's the end of the story. Patient dies on the spot. So the message here is don't try to do anything with a stable foreign body. If the patient is ABC is okay, just send the patient to a specialized center. But if the patient is collapsed, not breathing, not doing well, then you have to try something to unstable the foreign body. Vocal cords, again, the common issue is voice change. Voice change can be due to many reasons. What we normally have to consider seriously is a voice change going more than 2 to 3 weeks, because a simple upper respiratory tract infection can cause voice change. Sometimes they lose their voice, aphonic, or disturbed, dysphonic. Whatever it is, due to the edema, inflammation of the vocal cords, it settles with treatment and settles with time. Any voice change going beyond 2 to 3 weeks, we have to investigate, because it can be a cyst like this in a vocal cord, it can be a polyp like this in a vocal cord, uh, or it can be vocal nodules on either side, especially in people who use their vocal voice, and it can be a can carcinoma even in a vocal cord. So the message is, any voice change going beyond 2 to 3 weeks, refer the patient to a specialized center. Until such time, you can give symptomatic treatment, common cold viral infection, and gastroesophageal reflux also can cause inflammation and edema of the vocal cords and voice change. The throat tonsillitis is a very common condition that we encounter, coming with sore throat, fever, difficulty in swallowing. But if it is going uh, uh, repeatedly, like 6 to 7 times a year, or consecutive 2 years, more than 5 episodes, 3 consecutive years, more than 3 episodes, recurrent repeated tonsillitis needs surgical removal. Otherwise, you can give mouth wash, mouth gargles, antihistamines, oral antibiotics time to time. Uh, I think that's for today, and we have run out of time also. So, any questions, anything specifically, I would like to. Uh,
Yes, madam. Thank you, madam. Madam Dr. Sanjeevani
yeah,
Rupasinghe, consultant otorhinolaryngologist, for that informative lecture. And there are numerous questions have received, madam. I'm sorry we can't go for all the questions. Let's answer some of them very briefly, madam. The first question they have asked: do we need to keep earwig? How long we have to keep the earwig inside the ear for otitis externa?
the earwig is going to fall off automatically once the edema is settled. It won't be there for 2 to 3 days, but uh, no harm keeping the earwig. You can go up to 2 weeks, but it will automatically fall off once the edema is settled.
And what about vacuum suctioning for wax removal?
That's the best. That's the best. Vacuum suctioning is the best. You have to soften the wax with some wax solvent and direct light vision. Vacuum suctioning is the best. But uh, most of our general practice clinics, I don't know whether the vacuum suction is available. The important thing is, you have to have a fine suction tip. You cannot use this large suction tip, which is not going to accommodate inside the ear. A fine suction tip, very gently, you can that's the best.
Madam, what is the management of a child diagnosed with atopic dermatitis presenting with external canal dermatitis with itching and canal accumulation of debris frequently?
Yeah, that's again a skin condition, atopic dermatitis, topical applications, corticosteroids, and antihistamines in the oral antihistamines. Frequent clearing of the debris also should be done. Otherwise, the debris moisture can lead to infections. In severe cases, severe edema, severe skin inflammation, uh, can add oral antibiotics as well. But this refractory type things, better to refer to a specialized center get opinion from a dermatologist, because this atopy could be due to many reasons. I have seen patients allergic to this fabric softener as well. So the moment they put on their clothes, they start sneezing, the ear is itchy, some soap also. So it's a condition where you need topical applications, antihistamines and antibiotics. But if it is refractory, please get an opinion.
And madam, what are good antibiotics, eardrops, and steroids? Should we use combinations or alone?
That again depends on the type of infection. If you suspect a bacterial infection with edema, better to go for a combination antibiotic and a steroid, because edema is going to be relieved by the steroid, and the infection the antibiotic. Plain steroid drops I don't recommend, but in a fungal infection, better to avoid steroids. We have pure fungal antifungal eardrops. We can use antifungal eardrops. That depends on the infection.
Is it useful to take oral antifungal agents for recurrent fungal infections in ear?
No.
How about using sodium bicarbonate eardrops for earwax removing? There are two questions.
Sodium bicarbonate eardrops is going to soften the earwax. There are multiple commercial preparations, so all contain sodium bicarbonate. But in small children, I use olive oil eardrops because sodium bicarbonate is sometimes uh, irritable to the delicate skin. So some people are allergic. So I normally use olive oil eardrops on small children, but in adults, sodium bicarbonate. When they are allergic to these products, they get itchiness and fullness of the ear as well.
So, madam, there was another question: taking oral antifungal agents for recurrent fungal infections in ear.
Because this being a localized infection, I normally don't advise having local antifungals, because that carries a lot of other unwanted side effects. It should be treated locally.
Okay, madam. And do we have to refer the patient to ENT's consultant if it is labyrinthitis, as it causes hearing impairment?
If your diagnosis is correct, labyrinthitis, this hearing impairment usually settles once the inflammation settles. But as I told you, the sudden sensory neural hearing loss needs to be referred to a specialist center.
Let's take this as the final question, madam. What is your opinion regarding use of antibiotics in uncomplicated sinusitis? Is it essential to use antibiotics? What is your idea about steaming plus mucolytics and combination for sinusitis management?
Yeah, and simple sinusitis, it's antibiotics not recommended unless you have fever or any secondary features of secondary bacterial infection, because all this common cold is 95% of the time viral. But if you have fever and features of secondary bacterial infection, yes, antibiotics indicated. Steaming indicated. Steaming plain hot water would do, because it improves the mucociliary functions as well. So it brings out all the phlegm inside the sinuses. Steaming is good. Antihistamines, anti-mucolytics, all is aimed to bring out all this phlegm outside, because if it is going to stagnate inside, can cause problems. So simple sinusitis, antibiotics not indicated unless you have evidence of secondary bacterial infection.
Thank you very much, madam. We could answer only few of your questions. I'm really sorry about that. And we're going to wind up the session. And thank you very much, Madam Dr. Sanjeevani Rupasinghe, for your informative presentation on ENT issues in general practices. We had more than 500 doctors in today's session, and your expertise has definitely given us all a good understanding of how to manage patients with ENT disorders. Your dedication to sharing your knowledge with us is greatly appreciated. To all our participants, thank you for joining today's free program. As mentioned earlier, the link for feedback and post-assessment questions is now available in the chat box. Kindly take a few minutes to provide your feedback and complete the post-assessment to receive your e-certificate within the coming week. Otherwise, you will not be eligible to have the CPD certificate. The SRE program will continue next Sunday as well with another relevant clinical topic. We warmly invite you to join us once again for another productive session. Thank you, Madam Dr. Sanjeevani Rupasinghe, Consultant Otorhinolaryngologist, Sri Jawadinapura General Hospital, for your time and for sharing your expertise. And thank you to all the other doctors who participated today. We look forward to seeing you again next Sunday morning. Thank you and have a nice day.